body which sits in Geneva and receives reports from the country as to their status and how they're doing on different aspects of economic, social, cultural rights, for example. And this data is a little bit old, but it's looking at how climate was assessed by these human rights treaty bodies in 2021. And so green is where these reviews started to look at what countries were doing and what they expected countries to do in the context of health. And what happens is you have these concluding observations, which these are all the different treaties, and then we can start to see which treaties are addressing climate change in their recommendations to countries and what they expect countries to do the next time they report back to the treaty body. And the green is the economic and social cultural rights, which is probably the greatest, more fullest description of what obligations stand under the right to health. So in addition to this conversation, there are also something that's known as human rights indicators, which typically take 3 different processes or aspects. So they can be structural indicators, process indicators, or outcome indicators. Structural indicators are how well governments have taken legal adaptation of the right to health in their own constitution, their national health policies. Process is how well they then take those obligations and implement them. And then outcome is how populations enjoy the right to health, so the population level of the right to health. So this is where it gets interesting. Like, how do we take all of that words, because lawyers love words, and translate that into meaningful health indicators that we can track? And then how do we track those that are explicitly impacted by climate change or climate disaster? And then the third step would be, how do we translate that into a tool which can be adapted by a community and used to hold governments accountable? So that was the subject of our workshop that we held in Stanford in late October of 2022. We were focusing on community mental health and the climate change crisis, and really bringing together a variety of different scholars. And so just so we get a little bit granular, this is, another slide on the rights-based approach. And so we understand that both you can have participation as well as accountability and transparency when you're talking to rights holders and those that are the duty bearers. Well, this is one group that's come out of Nicaragua to really try to be granular on what some of these sample indicators could be. So they were looking at the availability of water, how physically available so this is from the community's perspective, your perception of security at the water source, the quality both from the provider that's providing the water, and then the perception of the community of the water that they're receiving, who is actually without water, so community's perception of the non-discrimination of the delivery of the right to water in Nicaragua, and then where they could get information about both the rates, the quality, the security, and their physical availability. So this is a terribly busy slide, but this is from the treaty bodies as to different types of indicators that we could use when we're thinking about the right to health more broadly. And there's very little in there that's focused on climate specifically. So there's some discussion about unsafe natural environments and the prevalence of death and injury and disease. There's some on the number of cases of deterioration of water sources that were brought to justice and the proportion of households that are living or working or in or near hazardous conditions that have been sort of rehabilitated. But there's very little information and very little indicators that are focused on the things that we've been talking about here at ENBEL. So where do we go from here? We propose that the right to health can be translated into measurable indicators in the context of climate disasters, and they can be designed within a contextual framework that accounts for communities' needs and priorities, and could be then held by the community an adaptable tool. So right now, we've been working with Indigenous leaders in the United States primarily for probably since early 2023, so January of this year, looking to develop Indigenous-led, community-centered health assessments. So moving from risk and deficit assessments for vulnerability to asset-based ones, where we think more broadly about what health means in Indigenous communities and Indigenous determinants of health, and then pairing that with accountability mechanisms from the right to health, which allows for that broader thinking about the right to health. So my challenge to you, as we've listened to a lot of really great impactful work around health and climate, is to see if we can translate those programs and policies and science into indicators that we can track and hold governments accountable. Thank you.
Thank you very much. Oh, you can keep it. So we have a little time for question. Please stay here. Would you have any? Feel free. No formal discussion, so any comments maybe? No question, but a comment? I was myself wondering how you plan to make this tool available or to communities, or how to make them come to you to use this tool.
Well, so we've really been working with the communities to see, does it make sense? Right, the right to health, does it make sense in the context of the climate disaster response work that they are doing? And then really looking to them to say, okay, what does health mean? What are you looking for? Because right now there's a big gap between what healthcare institutions wish to do in climate disaster response. And so from there, once we have an understanding of what it means, that what are the core determinants of health in these communities that they feel really should interface with the institutions, that's how we're building the tool. And we hope to then allow it to be translatable to other communities. But it's community centered. So it isn't that we are going to a community to say, here's my tool. But really, it's been a long discussion, and it's been very always eye-opening to see how much the words that we use in the scientific community or in the medical community do not resonate with a lot of the work that's been done by frontline communities affecting climate change.
Okay, thanks. Any online question, maybe? Gunnar, any online question?
No.
Okay, so far, yeah. There will be some time at the end for discussion too. So let's move to the next speaker, who is Jean-Marc Houdet. Oh, okay, nice to meet you. So Jean-Marc, you are a public health medical doctor and sociologist. You're involved in the CLIM-HP project, supervised by Valérie Ride, I know, and works as a postdoc researcher for the French National Institute for Sustainable Development.
Thank you so much. Hello, everyone. It's a pleasure for me to be here. And I'm really happy because we talk about social science. And as you know, we didn't have so much attention during this seminar. So I'm really happy. I will share with you some insight from my ethnographic study in Bangladesh, focusing on mental health and climate change. Why addressing the mental health and climate change, how we can understand this subject, this question. What is really complicated because there is like the intersection of two global crises, climate crisis, but also the global mental health. And more than 1 billion of people who are suffering from mental health disorder are living in the low and middle income countries, but we never talk about this issue. So this is really complicated. This is a public health issue, and there is a lot of knowledge gap because most of the study are from the north, from the Western countries, when we talk about mental health, and especially when we talk about mental health and climate change. And we know that the most vulnerable people are living in the low middle income country, and they are living in the vulnerable communities. So there is a lot of challenge. You may be familiar with this diagram from University of Notre Dame. It just shows that the country, the more vulnerable, the little one, are the less responsible of the CO2 emission if you take the history. So this is just to say that when we're talking about climate change, when we discuss climate change, there is always question about social justice. And the other fact is, when we talk about climate change, we all know there is a lot of impact on health, but we don't know how it's possible to have impact on mental health. And this diagram, it's really, this picture is good because we can say that there is several impacts from climate to health and across health factors. Like if you take extreme heat, if you take infectious disease, you will have some health impact, but across each health factor, you can have mental health impact, but also directly from the acute event like extreme weather, heat, or from a cyclone or storm, you could have also direct impact on the mental health of people. That's why usually people, when we try to have a framework on mental health and climate change, we said there is direct impact and indirect impact. But this connection is really difficult to explore, to analyze when we are doing research. So my research was in Bangladesh, and as you know, Bangladesh is in the Bay of Bengal. 20% of the mondial population are living in the bordering, in country bordering the Bay of Bengal. And if you look at the topography of Bangladesh, what is really important is that there is more than 800 rivers. And I don't know if we can see on the laser, I have two fields, one in the capital, Dhaka, and another one in the southwestern part of the country. So this part, the southern part, is really exposed to major acute event, extreme weather, like cyclones, storm, sea level. So we have very different climate exposition. You can have the acute event, but you can also have, like in this area, Shatkhira, you will have slow onset event like acidification, salinization, and also high temperature. And in the capital, in Dhaka, you will have the exposition to heat. It make very vulnerable the people. So what is difficult is you have a combination of acute and slow onset event. And my fieldwork was in two communities, one living in a slum in Dhaka, and the other one a rural community, fish farmer, very poor, in Shatkhira district. So the objective was, it was an exploratory study, so to explore the impact of climate change on two vulnerable communities. And after analyzing all the data, there is two specific questions. One in the rural setting in Shatkhira, how does social status shape the mental health of people? Because we can see a lot of this variation among people because of the social status. And in the slum, it was more about the survival strategy. We were talking about economical strategy. So it was ethnographic study. It was the first fieldwork was before the monsoon, during the heat season in April last year, and the second fieldwork was after the monsoon. And what is important in my methodology is that I've chosen like 15 households, and each time I went to the same household during several interviews inside the household with the daughter, with the mother, the father. And this triangulation helped a lot to improve the quality of data, to have a real relationship with the people, and to build a trust relationship. And actually, I also made my last fieldwork. It was during the monsoon 2 months ago. So what is the main findings? There is some key social determinants identified. First, the social status, especially in the rural area. Secondly, the combination of economic and environmental factors. And the last but not least, the gender differences especially between father and mother. First, for the social status, what was really important is in the village, if the social network could make a lot of difference in terms of access to healthcare, because Shatkhira is near to India. So some of the people who have the best social status in the village were able to go directly to India because they have some connection to have access to healthcare. And even because of a lot of degradation on the crop production, the impact on economic and financial was huge. And so if you have more network and good network, you can have other economical support. Second factor was the embedding of economic and environmental events. So like in 22 last year, in the rural area, we've seen that there is a lack of rain, no monsoon, absolutely no monsoon. So there is an increase of fishing, an increase of price on the market, and a decrease of the crop production. And it was like a spiral, a cycle of debt, and a lot of households were over-indebted because they took loan from NGO, from other people, and because of the lack of production. So the outcome in terms of mental health outcome, depression, anxiety, it was really a lot. And in the meantime, in the slum in Dhaka, the cyclone Citron beat the capital, but the most damage was in the slum because of the localization of the slum on a canal, on a river. So water was coming from the roof, but also from the ground. So it was like a situation very dramatic with a lot of tension, anxiety, and psychotrauma. And so to finish, the last factor, the gender differences. So there is a lot of gender differences because especially during the heat season, mothers have a lot of increase of caregiving responsibility because children are not able to sleep during the night. So they just try to fan them manually because electric fan cannot function. And so they cannot sleep. Even the children cannot sleep. So during the day, they have a lot of behavior disorder and the mother are focused on that. So a lot of anxiety, a lot of also depression because there is a lot of food insecurity because of the decreased production of crop. And the mother are responsible to give the food to the children. So a lot of challenges, many challenges for the woman. And this insight, we also find it in many papers in the literature. And for the men, it's also really difficult because in the slums, they're not able to have work and they're really poor. So for the men, there is a lot of addiction, drug addiction in the slum. So a lot of conflict and gender violence about the money. How do you manage the money of the household? So to finish, just some recommendation to prioritize mental health support in vulnerable communities, to try to make solution with the community from the local to the global, and to have some gender responsive policies. In conclusion, so the three key social determinants: social status, gender, economical strategy. And what is really important is to also to understand the dynamic of the interrelation between economic and environmental factors. Thank you very much.
Thank you very much. To you. Do you have any questions or comments? Yes, please. I think well, just one mic. Sorry.
Thanks. Hi, thanks for a nice presentation. Going back to your recommendations, how was it formulated? Prioritize mental health support in vulnerable communities. How realistic is that? I mean, is it feasible when the most basic needs like access to clean water, access to food are not covered? How can you make sure that policymakers in this area will even consider prioritizing this? Thank you.
You can come closer for the discussion if you, because I have only one microphone.
Thank you for your question. Yes, absolutely. It reminded me when I started the fieldwork, people were saying, oh, you were talking about mental health in this community. It's not possible because it's survival strategy. It's not mental health. Actually, when I talk with them, all people told me we have a lot of tension. We have a lot of anxiety. And you cannot separate, like if you need food, you also need to sleep correctly. So mental health, you know, the WHO, they say mental health is health. So you cannot separate mental health like an indirect impact, something you go after. It's really in the same time. And if you have a good mental health, you will be able to work. You will be able to find another strategy, another solution. So from the local communities, when I'm talking about mental health, for them, it's really important. But when I'm talking with health professionals, they say that mental health, we don't know what you're talking about. So there is a gap between the basic needs from the community and the local community who say that, yes, this is really important, the mental health support, because I'm not able now to sleep the night. And I can see there is a lot of conflict with my husband, with my children. So there is a lot of impact in the daily life. So I think there is a lot of stigmatization about mental health. That's why we are not able to address this issue.
Any more questions online, maybe?
Yes.
For online people, the microphone.
Oh, gotcha. Okay. In terms of what I always feel like as a clinician, I always wonder where should one best put all your efforts in? For example, is it better to work to mitigate climate change so that you reduce these factors that lead to mental health problems, or is it better to invest your energy in creating solutions for the mental health issues that are happening? So maybe it's a little bit of a mitigation adaptation, type of a question. And I just wonder, like, in a community like that, what would, where do you recommend that the efforts be best invested in?
Thank you so much for your question. Yes, I'm not sure about, first thing really important, even for mental health issues, first is like just to talk about that, the awareness of the situation. This is maybe the first medication. Medication is like the therapy, it's the last step. So there is a foundation, Sajida Foundation in Bangladesh, that try to have like 3 levels to give a solution for the community. The first level is just to talk about this issue within the people. So awareness. The second level is when you have see there is some anxiety, try to have some therapy, collective therapy, but without medication. And the last one, when really we need that, to have a therapy with psychiatrist and with medication, you could have this kind of support. So I think maybe to build the solution, what is important is to make it with the local communities, and after you go from bottom up. But maybe medication is the last step, and the first step is really to talk about this kind of issue with the people. Thank you.
Thank you very much. No more questions? Thank you. So now the next speaker is Reija Ruuhila. So Reija, you are a senior climate expert at the Finnish Meteorological Institute. You have made a long career at this institute, both. You provided the information late, so I wrote it manually, so I cannot even read myself. So sorry.
Maybe I introduce myself then.
Yes, sure. That would be easier. Thank you.
Yes, so really I have a long career at FMI doing weather services, or operational weather services, climate services, and then I ended up to make climate change health impact research. And why? Here we jump now from Bangladesh to something very exotic, to Finland and wintertime problems and equity issues related to slip and fall injuries in Finland in wintertime. And the format of my presentation is such that, because it's now kind of new novel issue to make narratives in order to make impacts more understandable. So now you will hear my own real life case study of slip and fall injury last winter. Before I move on, I make one little survey. Could you please raise up your hands, those who have slipped and fell down within 1 year? Wow. Could you please stand up? In Finland, if I make this question, about 30 to 50% of the people stand up at this phase. And now, did I give you permission to sit down? How many of you need to seek doctor's treatment? Did you need to go to a doctor? Hands up again? None. Okay, thank you. Now you can sit down. Yes, this is actually about this size of room. Participants, maybe 1 or 2 persons, have slipped and fell down during winter time so severe that they break their wrist or so. So now, if somebody would like to share, what kind of experience do you have? Maybe I start from you. Where do you live, and how did that happen?
So I live in Oslo, and probably because I'm new to Oslo, and probably I don't know the reason, but it's mostly when there is sun after a period of snowfall, and the temperature rises above 0. There is solid ice, and that's when I tend to fall down. I do not know if I wear the right shoes. I walk in the correct way, if I'm the right penguin in Oslo. So.
Okay, thank you. I think maybe I don't need to present anything more than this. But anyway, I go on, because you are not very typical person who gets injured. Little bit background of my presentation. I have a little bit background, and then I end up to study a little bit what went wrong in my case and a little bit about the future. But especially I want you to remember about the inequity issues related to sleeping injuries. FMI, Finnish Meteorological Institute, developed this weather service for pedestrians about 20 years ago, and it is really demand-driven development. Ministry of Health and Social Affairs took contact to FMI that could you please start developing weather service for pedestrians in order to prevent these sleeping injuries, to be some kind of service similar to road traffic for severe weather conditions during wintertime. And motivation, about 75,000 sleeping injuries take place every winter. The way that people really need to seek the medical help. And leading to long sick leaves and costs. At the moment, the latest estimate was about 2.35 billion euros. And so we started first piloting. I was leading that project to develop the service, and in 2004 we launched operational weather service to warn pedestrians for sleeping injuries. And they are available at FMI web pages online. And there's also one, we are very lazy to publish anything the way that's why maybe it's not very well known that we have service like this. But there's also this one paper about road surf pedestrian weather model. We issue every winter about from 5 to 20 warnings per region in Finland, depending on the, a little bit on the region and what type of winter we have, whether we have mild or cold winter, it varies. We know quite well what are the conditions when the most slippery conditions are, how they are formed. When the temperature, when we have snow or ice, and when the temperature varies around 0 degrees, there is a cycle of melting and freezing. And then we get the kind of smooth layer of ice. And if it's a little bit snow over that ice, when the temperature is below 0, so that it's almost no friction at all between the shoe and the surface. And another very slippery case is that when the icy surface melts, or a little bit water, rain comes to over that layer, so it's also almost, in that case, friction is almost 0. So we have modeled these cases, and so we are forecasting, and we are pretty good, relatively good in forecasting. 9 months ago, January 12th, we had a case like this. We had the latter case, very severe, very slippery pavement conditions, water above ice. Our road surf pedestrian model forecasted it, and on the right side you can see also the official weather warning map of FMI, and so we warned about it. Slippery conditions, they were also visible. It was this type of a little bit water on the ice type of slipperiness. And what happens? I am expert doing this work for 20 years. I was in hurry, leaving FMI office building after a long working day. And there, beside FMI office building, I slipped, fell down, and broke my wrist. It's still visible. And well, what happened? First, they put a cast over my hand, but 2 weeks later, they realized that it has to be operated, and here it is. Here it is. My hand is never coming back to normal anymore, but anyway, it's working. Long sick leaves, 6 weeks full-time sick leave plus 4 weeks part-time, 50%. So if you think about the expenses for FMI, or not really FMI, but anyway, you know, I'm not quite the cheapest person in the institute. And what I didn't realize as myself as a sleeping injury expert, how quality of life is really lowered because of such incident. I couldn't have my hobbies, and I got some weight, and so I don't know how long it will take before I get back to normal. So now I know that this problem is actually much more difficult than I expected based on the numbers and an understanding of the phenomena. And I'm not the only one, 75,000 about in Finland annually. And now we come to equity issues. Typically, women are more at risk than men to slip and fall. And then, okay, if we think about numbers, the age groups, young people typically they slip and fall more often than elderly, but they don't get seriously harmed. But then by age, the consequences become more serious. So I happen to belong to this group and this group. Yep, so I belong to the risk group. Women over 60 years suffer from the most serious consequences. It's related to the aging and, for example, how fragile bones do you have and things like that. But what can we do? And now I have been doing some serious thinking. What went wrong? Thinking that I understand the phenomena and yet I was there. Why was I there? Thinking about a little bit theoretically how to get best benefit out of weather service. In ideal world, weather forecasts are accurate and they are very well designed for the customers, and they or the users have access on time, you know, the further services, and they understand the way that they should be understood. And then comes the responsibility of the user. How well are the users able to respond, and how effective are the responses? In ideal world, you know, we would have 100% accurate forecasts, and end users could use them 100%. Well, we are never there. Now the flashing here indicates the location what went wrong. We had all those services. I understood and you know perfectly well what was the situation, and yet it happened. What are the effectiveness of responses? Yes, I blame a little bit myself. Responsibility of the individual. I was aware, but I was in hurry. I didn't act according to my understanding. Well, but then comes the issue what we are talking about in equity. Quality of the winter maintenance, and in general, the transport system of the city. So if we start to compare a little bit the efforts, if in Finland we have about 75,000 pedestrian slip injuries each year, and we compare to the road traffic accidents, about 4,000 people get injured in road traffic accidents. So the numbers are quite shocking, aren't they? And costs, the sleeping injury costs for society are higher than in car traffic accidents because these wrist fractures, and so they are very difficult to treat, leading to long sick leaves, etc. So what are the equality and inequity issues? Gender. Women walk 1.5 times more than men in Finland. Men drive more with cars. Children walk more than adults with obvious reasons. And gradually, people get older there, and or if you have if you have disabilities, you may not be able to move as much as you would like to. Income: wealthy people have more cars. And this makes me think, throughout the 20 years that I have been working with these issues, I've been wondering the investments that we have. Winter maintenance, it is very clear that winter maintenance of roads for cars, the car tracks, is better, and the quality is more uniform than the maintenance of the sidewalks for pedestrians. And then we come to conclusion that walking is not considered as important form of traffic or transport in urban planning or designing of traffic systems. And we have studied about that. Sorry, it's only in Finnish until now. But some of my results later on refer to those. And I can see it also in weather service. We had been developing road weather service, for its very old traditional service, and where this pedestrian weather service, it's something new and still novel. So I have a little bit more information about this risks. So here you can also see that per kilometers to travel, walking is really the most risky one. And happy thing is that awareness of slip and fall risks have increased. And on the right side, you can see that this light blue colors, they indicate the use of these anti-slip guards that people using, and use of them has increased in Finland, even among young people. So awareness has been increasing. We can't see it really in statistics if you see the time series. So that's difficult to prove that information campaigns would have really affected so far. But about the future, I would like to say that what it has to do with climate change. Actually, what we can have a look at this slide here, because this is the whole period from September to May. So kind of normal sidewalk conditions will increase because winters are becoming, sooner or later they are becoming shorter, so the slippery risk period is becoming shorter. But this kind of slightly slippery conditions will decrease. But the very slippery conditions will increase because we will have more this zero variation, the temperature variation around zero. So risks may be increasing. Lucky thing is that there are, because of climate change, we aim to, or we are already promoting walking and cycling that as a climate-friendly form of transport. And it means that ministries and so on, they need to do some work in order to make also safe conditions for walking and cycling. So maybe we get improvements for this inequity issues between different forms of transport.
Thanks very much. Very interesting. I have to say I've been living in Montreal, so I know what it is, what you're talking about. Actually. Any comment or questions? Yes, please. Thank you.
Yes, thank you very much. Very interesting. I was just wondering why that age group above 65 had less of a risk. Is that because they're more careful than our age group, or they're wearing the anti-slip? Because normally that's a vulnerable group. It's the over 65.
65 people over 65, they tend to be already retired. So actually, this is not Yeah, this is working problem for working age people, and then comes to above 50 because we have then not be in good shape anymore.
There is a question over there.
Just a comment. I'm not Swedish, but I do know that I live in Sweden, and that where I live, the pedestrian sidewalks are first treated, and often the car streets are not. So I think that's a change of mindset, and I think it happened a couple of years ago. So it might be interesting to look at.
Yeah, thank you that you brought this up, because this is something that actually we made a report, or that we wanted to see that, because we knew about that possibility that in Sweden sidewalks have been prioritized in certain locations, and obviously also in Canada. But maybe they are just pilots yet. But this is what we try to promote also in Finland. Or I hope that we get forward.
Oops. What about sleeping in the rooms? That's another problem. Sorry.
Thank you very much for bringing attention to such a case. I was wondering if you had also data about pregnant women and sleeping, because it's also a time where they might be more vulnerable. And that has been an issue, for example, in Norway and in certain areas, especially related to the need for medical assistance afterwards.
Not to my understanding, it doesn't ring me any bells, but I'm just started to think about the shape of pregnant women. And because this is quite a lot of question about what kind of ability to or capability to have balance you have. So I think it might be kind of risk for pregnant women. And yeah.
Thank you very much. We'll move to the next speaker now, who is Dr. Daniele Tite. Where are you? Welcome. So you are an associate professor at the College of Health Solutions and a senior global future scientist in the ASU Global Institute of Sustainability. And you're the expert on substance use disorder for the research team.
Yes, thank you so much. I'm really honored to be here and represent my team. So I'm from right now work at in Arizona, but originally I'm from Lithuania. So I have a lot of experiences with falls in the winter, but not in Arizona, thankfully. So our presentation focuses on overdose-related deaths and other injuries and heat-related risks. And this topic hasn't been explored very deeply so far. So as some of you may know or may not know, US is experiencing really profound crises, public health crisis related to opioid and other drug use mortality. And we have over 100,000 people dying from overdoses in the United States. And in Arizona, we see similar trends. We see continuing increases, and there are a lot of efforts to address the issue, and it's really very challenging and difficult. We have almost 3,000 people dying from overdoses in Arizona. A little bit about Arizona and Phoenix. It's located in southwest of the United States. Phoenix is the largest city in Arizona and also the 5th largest city in the United States. It's located in Maricopa County, which has about 5 million people. So it's a large urban center, and it's located in Sonoran Desert. So it has high temperatures. It's really hot in the summer. It's sunny, hot, and dry climate. And our summers are usually, we have temperatures over 45 degrees Celsius many days of the summer. So it's really very hot environment. And with a growing, city that has grown so significantly, We also see very big impacts of so-called urban heat island effect in the region. And these are some of the graphs that it demonstrates increasing temperatures in Phoenix, and especially in relation to the urban growth with the years from 2003 to 2019. You see the changes happening. And these changes are also visible in the heat-related mortality numbers that we are seeing in Phoenix. So in 2022, we have over 400 people die from heat-related illness in Phoenix area. And this was a significant increase compared to prior year. And for this year, the numbers haven't yet been compiled, but we are on the trend. We see a trend that is much, much greater than what we have seen in 2022. And heat-related illnesses that we have seen, or mortality, is really, really interconnected with drug use. So over 50% of people who are dying from heat-related illnesses are also, testing positive for drugs and alcohol. So we see an important intersection between the two risk factors. And, looking into numbers of heat-related mortality are really impressive and really, heartbreaking, but this is just the tip of the iceberg, right? There is a lot more that is going on, and we have not yet been able to uncover the real impacts that are going on in relation to drug use or other health conditions. So just a little bit more about the background to what is happening in Arizona. We have drug use issues related to fentanyl. Fentanyl is a very potent opioid. It's highly available. It's just replaced most other opioids in the region. And we also have very plentiful and inexpensive methamphetamine, which is a stimulant drug. And methamphetamine is oftentimes used in conjunction with
actually everything that we saw that was a heat-related death at Maricopa County Hospital at Valley Wise. But in the industrial setting, in the United States, a series of people who had heat stroke death, over 80% of those people tested positive for a substance. So it's hard to say where do you draw the line. Someone has a high temperature, then it's heat related, but the opioid may have been a contributing factor. So this data on pure overdose probably underestimates the impact of opioids in the heat, not overestimate. So I would say that there are a lot of heat deaths that have an opioid as a contributing factor rather than opioid deaths that are really heat deaths. So it's hard to separate them, but opioids probably play a much larger role in just heat deaths that are called heat deaths, at least in Maricopa County.
Last question.
Yeah, thanks. My name is Julia. I'm from Cicero. Thanks. It was a really interesting presentation. And speaking about overestimation and underestimation, I'm thinking about the regression that you showed earlier, because you mentioned that you use Cicero data from satellites. And I'm also conducting some epidemiological analysis. And usually when we do that, we use time series data that is hourly. So we use either observations or model data because we want to see maximum temperatures, minimum temperatures, mean temperatures during the day. So I'm thinking that you could perhaps underestimate because the satellite only passes through one location once or twice a day, right? So you might be underestimating your regression, your coefficients, if you take into account only satellite data. So maybe something to consider.
Yeah, so we're going back to looking at ground sensors as well. So we have another data set of heat that we're currently running with this. But the interesting thing from the Cicero data you'll notice is that it was the high lows. It was the minimum temperature. That correlation is with high low data, not so as with many heat related illnesses. It's the high low that is more important, and that's what the Cicero data analysis showed as well.
Thank you very much. Oh, okay.
Aqua data for this, and what it does is that there are two overpasses. So one during 1:30 in the afternoon, and the next during 1:30 at night. So you really get the highs and the lows. So 1:30 is very close to when you get the daily max. And now the advantage of using satellite versus reanalysis that you're talking about is another vision of discussion, but I mean, we can do that separately. Yeah.
Thank you very much. So I suggest we move to the next one. So Julia, and I suggest also that we will have the next presenter right after you and the questions at the end. Otherwise, I'm afraid someone won't have time to talk.
Hi, everyone. My name is Julia Marginian. I'm a PhD student at the Cicero and University of Oslo in the Meteorology and Oceanography department. And I want to present to you today some preliminary findings from my PhD project. It's called ENBEL, Embodying Climate Change, Transdisciplinary Research in Urban Overheating, where we have 2 case study cities where we study experiences of people with heat, as well as conducting climate and epidemiology analysis, and also more recently demographic analysis. And I'm going to explain why in a moment. So I'm going to focus today on modeling vulnerability and how we assess the complexities of heat-related risks in cities. So just to give you a little bit of context, the World Health Organization, as it was mentioned earlier today, has called climate change the biggest threat facing humanity, and the Intergovernmental Panel on Climate Change defines threats or risks as a function of hazard, exposure, and vulnerability. And I'm going to briefly touch upon all of these 3 elements, but I want to focus specifically on vulnerability a little bit more. And we can think of vulnerability as a combination of sensitivity and adaptive capacity. And when we talk about sensitivity, we think about certain population groups who are more susceptible to heat stress than others. So for example, older adults, in some cases women, and those with a low socioeconomic status. And because of the very clear interlinkages between socioeconomic status and educational attainment, we can use education as a proxy. So this is the reason why we use demographic analysis, because all of these factors are demographic factors. In terms of adaptive strategies and adaptive capacity, we can think of it as adaptation strategies at the city level, but also individual coping mechanisms or changes in behavior and so on. But as it was mentioned several times yesterday, and today as well, the question really is, how do we use these vulnerability factors to better inform adaptation measures? And this is what I'm mostly focusing on in my PhD and also in my talk today. So from epidemiological analysis, we can see in the case of Madrid that older adults have higher risks to heat stress. And this increases together with age. Also, women are more susceptible to heat than males. And for Warsaw, I did not put the numbers on these graphs because they're just preliminary graphs, so I'm not going to go into details on that. But from Warsaw, we also have mortality based on educational attainment, and I'm only showing high and low here because the medium educational attainment is in the middle, and we can already see the differentiation in risk between also age, sex, and education for Warsaw as well, even if it's not so prominent as for Madrid. And if you're a decision maker in a city, you have several options for adaptation solutions. There's many things that we can do to reduce the risk of heat. We can increase green and blue spaces, so parks and water fountains in the city. We can install cool centers, work on building insulation, making sure that people have access to drinking water, or checking on those who live alone. But to know to make these adaptation measures as effective as possible, we would like to target them towards those who are most vulnerable, so those who are actually dying from heat stress, right? And to be able to do this, we need the local knowledge at the intra-urban level to be able to understand better where to implement these solutions. So just to show you how important high-resolution data is, here we have 1 kilometer maximum temperatures data from WorldClim dataset for summer months. These are averages from 1970 to 2000. And when we go down at these scales, we can already see that some regions in the city are more affected by temperature than others. Now, if we combine this with different vulnerability aspects like age, for example, we see that the patterns of vulnerability or of exposure change. So the city center will become more exposed than the outskirts. But if, on the other hand, we look at education, constructed these maps for several age and sex groups and for all low, medium, and high educational attainment levels. But what I'm showing here is perhaps the most vulnerable population group. In Madrid and in other cities as well, it's a female population above the age of 85 with low educational attainment. And we've been talking about scenarios in several presentations yesterday and today. But the first panel shows the sustainable development scenario that is in line with the Paris Agreement. And we can see, if we look at the changes between 2012 and 2050, for which we have conducted projections, we can see that the share of this very vulnerable population group is decreasing in almost all areas of Madrid, right? But if we look at the middle panel and on the at SSP3 as well, the middle panel represents a scenario that follows the current trends. It's called the middle of the road scenario. We can already see that there's some disparities between the richer areas, the city center, and some areas in the north compared to the southern areas and eastern areas of the city, and even more so in SSP3, which is it's the regional rivalry scenario where inequalities are increasing a lot more compared to SSP2. So how can we really measure heat stress based on such vulnerability modeling frameworks? So we can see from epidemiological models that some groups are more vulnerable than others, but this information is at the whole city level. We can also use high-resolution demographic data that to see that the neighborhood level effects. But the question is, how do we combine them? So if you're a woman aged 80, what is your risk then? So this is a question that we're still working on how to address this. But so far, we can see that the scenarios and global trends within scenarios have a very strong influence at the very local level. There are significant differences in vulnerabilities between the neighborhoods in one city, and that factors like age, sex, and education do play a significant role in the temperature-related risks. But from now on, we want to include other vulnerability factors, such as proximity to green and blue spaces. We want to look at health factors or economic factors and combine them and test different approaches to see what would be the best measures to understand better the common vulnerabilities within a city. And we would like to use these frameworks and these results to inform better adaptation measures and their efficiency, as well as to transfer to other locations. Thank you.
Much. Oops. Yes.
About your
sorry, I forgot to. I was saying to please ask your question, and then I go back to the next speaker.
This is a quick one. You have future scenarios, population growth according to different scenarios. How do you distribute the people inside the city? Is the city how urban development is taken into account, or is it taken into account?
Sorry.
Yeah, so we do account for, apart from the different educational attainment shares, we account for mortality, fertility, and migration, which are the basic factors that you have to take into account when you make demographic projections. And I think internal migration is one of the factors that plays quite a big role in the projections that we see from the models.
Okay, sorry. So I'm calling for the last speaker, Isham. Sorry for that. So we ensure to listen to you, and then we'll finish with questions for both of you. Yes, this time, yes. So Isham is a Marie Curie postdoctoral fellow at the French National Institute of Health and Medical Research, and visiting researcher at the